Good afternoon, everyone. So we just want to give 5 more minutes for participants and panelists to join. So we'll just start by exactly 3:06. So we'll just give a few more minutes. Thank you. Good afternoon, everyone, and welcome. So currently we have over 68 participants, and it's 6 minutes past three. So we'll just start. So good afternoon, everyone, once again. And whether you're joining us from a labor ward, as we can see, a PHC, or the State Ministry of Health, a boardroom, or somewhere in between, we are genuinely glad that you're all here present. My name is Shegun Oladipo, and I'll be the facilitator for webinar today. Together with my colleague Hawa, we are going to walk through everything we have lined up, making sure that you leave here not just informed, but ready to act. So I'll just like to reiterate that this is not another webinar, but about what happens in the critical minutes after a woman gives birth, as well as evidence that backs all of those up. And better to act, better to give, and how fast all of that should be done. So we have a tight and we have a powerful package here, and we promise you that if you stay with us till the end, you will not leave here uninformed. You leave here more informed than you came and ready to act. So before anything else, I want to hand over to one of our leaders here at Smiles for Mothers. Our welcome address will be given by Chukwunonso Nwakorie, someone who has dedicated most of his career to the question of why Nigerian mothers still die from preventable causes and what we can do about it. So he leads the maternal health portfolio at CEDA, and as the program director for the Smiles for Mothers, he has been one of the core engines behind the work we do as a team, and even for the maternal health effort here at Sodina. So let's give a warm welcome for Dr. Chukwunonso Nwakorie. Over to you, Nonso.
Yes, thank you very much, Shegun, for that introduction, kind words. Good afternoon, everyone, and thank you for joining us today. I would want to start by especially acknowledging the Director of Family Health at the Federal Ministry of Health and Social Welfare, Dr. Raye John, who is unavoidably absent, but he has kindly asked Dr. Samuel Oyini, who will be speaking shortly, to represent him, and he will be delivering the opening remarks. We are indeed honored by your presence and leadership, especially in advancing maternal health outcomes in Nigeria, but also importantly, just coordinating all the partnerships that make this work. On behalf of the Smiles for Mothers program, it's really a pleasure to welcome everyone to this webinar, which is titled Advancing Rapid Protocol-Driven Responses to Postpartum Hemorrhage in Nigeria. We're really delighted to have amongst us policymakers, clinicians, and other development partners. And as some of you who have joined our previous webinars will know, this is one in a series of webinars around preventing and treating postpartum hemorrhage, which remains one of the, if not the leading cause of maternal mortality in most parts of the world and here in Nigeria. It is also largely preventable and manageable when the right interventions are done, which is why we really bring these webinars your way to make sure that no woman dies because of PPH. So really these days, the challenge is not really about it's not really just about knowing what to do, but ensuring that the right actions are taken quickly, consistently, and as part of a clear protocol. In our previous sessions, we've focused on strengthening prevention and improving early detection, and of course, recognizing that these are the critical foundation for better outcomes. And as we go today into treatment, we also want to reiterate that prevention still remains the first line of defense, prevention of postpartum hemorrhage, especially through the use of active management of third stage of labor, including use of quality uterotonic, still remains the first line of defense. But sometimes we still come down with, or the women still come down with PPH, which is why today's conversation, which centers around the use of the emotive bundle, is really critical. So this is why for us, we believe that as clinicians, as program designers, implementers, we need to always think of the woman end to end, starting from prevention to early detection, and of course, timely and complete treatment. So as I said earlier, today's session is themed Advancing Rapid Protocol-Driven Response to Postpartum Hemorrhage in Nigeria, and it builds on all our previous session. This session aims to bring together perspectives from different frontline actors, clinicians, line managers, who make those critical decisions about how women are treated. And for us, we're hoping to move beyond just discussion, but highlighting actionable insights that are practical and can be used when each of us go back to our places of work. So we really call on you to participate actively. We will be having a few polls during the course of the sessions. Please interact with them. Hopefully, they will be as insightful for you as they will be for us. And we really do value your insights as we go. So with that, I really want to once again, on behalf of the Smiles for Mothers team, which is made up of colleagues at CEDA, CHI, and HSDF, really thank you for joining us. And I'll hand over back to Shegun for the next speaker. Over.
All right. Thank you so much, Nanso. That was a warm and grounding welcome. Now we'll hear from someone whose work at the policy level makes everything you're about to see and hear possible. What we are doing does not happen in a vacuum. It is backed by policy, commitments, national strategy, and the full weight of the Federal Ministry of Health and Social Welfare. So I'm privileged to introduce Dr. Samuel Oyeniyi. He is the Director and Head of Reproductive Health Division at the Federal Ministry of Health and Social Welfare. Few people currently in this country have dedicated more to advancing the cause of safe motherhood. Dr. Oyeniyi's division is the engine room of Nigeria's reproductive health agenda, from policy development to implementation, from evidence generation to advocacy. So his presence here today is a statement of the government's resolve. Sir, over to you to give the opening remark. Hi, Dr. Oyeniyi. I don't know if you can hear us. And if you are speaking, you're muted.
Yes. Are you hearing me now?
Yes, we can, sir. Please go ahead.
All right. I want to thank all the organizers of this meeting. Looking at postpartum hemorrhage, we've done a lot as Nigeria. On behalf of the Director of Family Health, Dr. John Ovoraye, who I'm standing in for, to let us know that all the efforts you
Hi, sir. You're breaking off a bit. We can't hear you at the moment.
It's coming. Sorry, my phone has been.
We can hear you now, sir.
Using my phone where I am. Yes, I'm using my phone where I am. Let me just quickly hand up. So I wish us fruitful deliberations. We will continue to support the reduction or crashing of maternal mortality. All the efforts will also be a priority for postpartum hemorrhage. I want to thank Solina for everything coming up with this webinar. I've been so busy, so many meetings. So please allow me. I need to attend to another thing now. I wish us fruitful deliberation. We are here to support you. The department will also support every effort on postpartum hemorrhage. Thank you.
All right. Thank you so much, Dr. Oyeniyi. Thank you so much for the opening remarks, sir. So what strikes me from Dr. Oyeniyi's opening remark is just a reaffirmation that the policy is there and the commitment is there and there is the evidence to back it up. So what we need essentially is for every one of us here at our facilities and wherever we're working to meet these commitments with equal urgency. So very briefly, we'll just go over we have a pre-poll. So your insights are valuable to us. So just to kick off this webinar, we are going to take a poll. So currently up on the screen, we have the QR code for you to scan, and we'll also be dropping the link in the comment section. We just have essentially 1 minute to do this, just so that we can get our insights to make this discussion rich for everyone. Please, let's go ahead. Either you scan the QR code or you use the link that has been deployed into the comment section. There are just 2 questions, and your honest opinion matters. Just 1 minute to answer those questions. Scan the QR code or use the link in the comment section. The first question is the most important. Yes, we can see people answering. Some people think early detection is, while some other people think all the components are essential. Let's keep answering. We have 34 responses. So we'll just take a few more before we move on. Currently, the highest votes go for early detection over all the other components of the emotive bundle. Thank you for your responses. I think we should just keep answering. All right, thank you. So we'll move over to the next question. How confident are you in your facility's ability to manage PPH effectively from detection to treatment using the complete emotive bundle? So let's just send in our responses. Okay, I can see a very strong, very confident response there. Thank you. Let's get more responses. Okay, thank you. More people are responding. We'll just do this for about 30 more seconds and move on. All right, thank you. Let's keep responding. All right, thank you, everyone. I can see we are still responding. So I think we have many responses now. Now we'll just forge ahead. Okay, so what we'll just do next will just be a quick look at what we have on our agenda. Okay, so on our agenda today, we have 2 major sessions. The first session being from prevention, detection to treatment, how emotive closes the PPH response gap. Underneath that session, we'll be having 2 presentations, followed by a Q&A session, after which we'll have the second session, which is a panel discussion. We have representatives here that would be taking us through a very insightful panel discussion, after which we will have another Q&A session before we take the poll again. Just to mention that we'll have maybe 1 poll mid presentation, which will be after the first presentation. So I'll ensure to prompt us when we are at that point. Okay, so for the first session, from prevention, detection to treatment, how emotive closes the PPH response gap. As we're all aware, Nigeria accounts for a great number of the total maternal deaths globally, because nearly 1 in 5 women who die giving birth anywhere in the world actually die here in Nigeria. And the number one cause for this is postpartum hemorrhage. So just like Nonso mentioned earlier, we actually have a phrase on the Smiles for Mothers program that I want everyone to hold, which is PPH is better prevented than treated. Prevention is not just safer, it is cheaper, less traumatic, and far more effective. So these are some things that I want you to hold. And please remember, as the presentation is going on, keep typing your questions in the chat box. We will come to them. So for the first presentation, linking prevention and detection to treatment, I cannot think of a better person to walk us through this than a specialist. He's a maternal health specialist at CEDA, a clinician and a researcher who sits at the intersection of evidence and practice. So his presentation is titled Linking Prevention and Detection to Treatment to Close the PPH Response Gap. Please welcome Dr. Chinedu Obikili. Thank you.
All right. Yeah, thank you very much, Shegun. And I think you've set the background quite well. So I think over the next 5 to 7 minutes, I'll just take us through a list of the evidence and a list of the problem that we are encountering basically in the country. I think for starters, I think what's very visible, if you look at the map that's there on the left, you can see Nigeria is really standing out. And I think even something to call out on this map is a map showing the maternal death toll across countries. So when it comes to total number, like Shegun mentioned, about 25% of all maternal deaths that happen globally happen in Nigeria. And I can imagine that can be very alarming, because when you look at the global map, you can see such a small portion is responsible for almost a quarter of all deaths. And importantly on that map, I think we see Congo and India there as well. And that's a total number shown on the map, not even the rates for the maternal mortality rates. When it comes to the maternal mortality rates, ours is still as alarming. I think our current statistic is based on 2018 from our NDHS, that puts us at 512 deaths per 100,000 live deaths. I think our data from 2023, we should be expecting it sometime soon. And the hope is that we see some degree of improvement from where we were the last time. But I think we're all aware that there are still too many maternal deaths happening in Nigeria. I think something needs to be done about that, certainly. And the leading cause of maternal mortality, globally and particularly in Nigeria, is postpartum hemorrhage. And I think as an obstetrician, and most of the health workers here will agree that for something that is so largely preventable and easily treated, it's almost unacceptable or unfair that so many people still die from something that is so simple to solve. I think that's part of why we are so driven by this at CEDA, because it's something that we know that is solvable, and there are just so many needless deaths that are occurring, something that's very easy to solve. And we realize that there are issues in the community, there are issues in transportation, but a lot of what we're speaking about today will be facility level issues and facility level challenges that affect postpartum hemorrhage. And I think, as you can see, one of the first things that come to mind is poor identification of postpartum hemorrhage. I think for the longest time, and still now in the large majority of Nigeria, people still attempt to use their eye to decide when there's postpartum hemorrhage or not. And I think from previous webinars, I think all of us would agree that trying to visually decide when there's postpartum hemorrhage is generally wrong. And that's why it leads to a lot of delays in intervention and slow treatment, which is the second point there, basically. So if you're not able to pick it up early, then there's no way you intervene in time and start talking about looking for blood, having bleeding disorders and things of that sort. So I think those are some of the core things that happen. And also there's also inconsistency in using recommended interventions. I think our continuous medical education system has its limitations, basically. And so a lot of health workers after graduation are not able to upgrade their knowledge. And what that means is that when guidelines change or when there is emerging evidence, if people don't intentionally search for knowledge, they will still be practicing based on old guidelines. And of course, that might just be outdated, which is the same thing as we are saying here about calling of updated postpartum hemorrhage guidelines. I think part of what we are here for and here to share, just to help people understand what is the current standard for PPH management and what are the best ways to achieve that. And I think one thing that will continue to sink over and over again is the function of prevention, because most of the postpartum hemorrhage cases can be prevented using good quality uterotonic. Unfortunately, a lot of people don't have access to this, and even when there's access, there are also issues with poor quality of uterotonics. I think what we see there in the image is the essay test that has been done in Nigeria, and you can see that as much as 74% of oxytocin did not meet the quality profile. And what that means, and that's why I'm sure we who are in the labor rooms can attest to it, that sometimes you give oxytocin, you still put in the IV infusion, you still give misoprostol, because the quality is really down. Oxytocin is a great drug. It works very well, but it needs a cold chain from the point of manufacturing to the point where it is used. And somewhere along that line, particularly in the Nigerian context, that cold chain is lost, and the quality of the uterotonic that we're using becomes lower, and we just are unable to do. I think that's why we have spent a lot of time also advocating for heat-stable carbetocin, which at least doesn't require that degree of cold chain, doesn't require cold chain at all. And so if you have that, then at least the quality issue is basically solved. So I think that's it. And even the misoprostol circulation as well, a large number of them have good quality tests. Yeah, next slide, please. Yeah. So we're going to be speaking a lot about guidelines. I'll focus a lot on the emotive trial, but we know that evidence emerged with time, and there are a lot of landmark trials that have been done. The first was the woman trial, which was to assess the early effect of tranexamic acid, and that was where the recommendation for use of tranexamic acid for postpartum hemorrhage treatment came from. Then we had the champion trial, which compared the non-inferiority of heat-stable carbetocin to oxytocin for PPH prevention. That's where we had the significant evidence in favor that shows that HSC is non-inferior to oxytocin, basically. And what we'll focus a lot more on today is the emotive trial. And if you notice, the champion trial and emotive trial both included studies in Nigeria. So that we know that our context was definitely kept into account. And the emotive trial was to evaluate the feasibility of a new solution addressing postpartum hemorrhage by focusing on early detection and timely treatment. And this was done in 4 countries, including Nigeria, in 83 health facilities, and using over 200,000 women. And the emotive bundle of medicines and interventions improved PPH detection, reduced maternal morbidity and mortality, and generally enhanced maternal health outcomes. I think one of the core recommendations was that the use of calibrated drip to objectively measure blood loss and a clinical bundle for first response of treatment for postpartum hemorrhage, including massage, oxytocin, tranexamic acid, effectively stops bleeding and prevents complications. And so that was one of the major recommendations. Now, one thing I've always liked about emotive and the emotive bundle is that aside tranexamic acid, it's not really saying anything new in reality. And I think a lot of us clinicians will understand that, because we've known for the longest time that you need to massage the uterus. We know you give a uterotonic, we know that you give IV fluids, but understand that at a certain level of care, not everyone understands it that well. And so just having like a catchphrase that says motive or motivation, it makes it much easier for even a community health extension worker to know what to do. We just remember motive. So as compared to when we used to have those drills where they'll say call for help, check for uterine contraction, if there's no contraction, give it a tonic, check whether the placenta is delivered, if it's not delivered, do manner removal. So it was so, I mean, when you have the knowledge, it's very nice to do and easy to do, but when you don't have the knowledge and you're confused, all you're seeing is blood there. So now once you're seeing blood come out, just remember motive and then you go ahead and do it. And it makes it much easier for even the lower cadre of staff to understand. I think one thing that we had highlighted earlier is that prevention is key. And that's why here we tend to use the acronym pre-motive. And so the pre is prevention, using a uterotonic, because a lot of the time, I think there's a Nigerian saying, prevention is better than cure, isn't it? And that stands really for postpartum hemorrhage. So knowing how to use uterotonic in a timely manner is essential, I think, within a minute of delivery. Oxytocin remains first line, but heat-stable carbetocin is very useful and very effective. And I think in our environment, that's also a very essential uterotonic that we need to always have handy. And then misoprostol is also there as an option. Now, the second thing is the E, which means early detection of postpartum hemorrhage. Now, a lot of us in Nigeria are not very used to use of the calibrated drape, but it's something that, and I think is becoming more and more popular. Because, like I mentioned earlier, using the eye to split blood loss is just not the way to go. And what a drape is, I think we've had a webinar on that before, is something that I just put on the buttocks of the woman for every drop of blood that comes out to then be estimated. And then once you get to 500 ml of blood loss, then you start and roll out the entire motive bundle. So that's the idea. Whilst previously the pad will get soaked and will be estimated, and we start to see a vital sign going down. But the vital signs are going down, it's often already somewhat late. And so it's important that once we get 500 ml on the drape, then we activate the full motive bundle. And I'll just repeat what the motive has means. I think I've already mentioned that already. The M is for massage the uterus until contraction. So you do that for at least 1 minute. I know you're supposed to feel the uterus become stony hard, and then that then serves as that supports that. And remember that the motive bundle is not to be done separately. It's to be done as one and holistically. So the O stands for oxytocin, which basically uterotonic. So oxytocin or misoprostol can be used. I think it's better to flag that whilst we know that HSC stimulates uterine contraction, but it's currently not recommended for use in treatment. I think the trial results will be coming out sometime later this year or next year, and then perhaps there can be a recommendation for use in treatment. But for now, the O stands for oxytocin or misoprostol is an option. And then tranexamic acid is what the T stands for, which should be given within 3 hours of delivery. It's an anti-fibrinolytic agent, so it just helps with blood clotting formation. And then we have the IV fluid administration for fluid resuscitation, and then examination and escalation if bleeding is not managed. Now, if we look at this, we understand that the bulk of this motive is for uterine atomy. This is the leading cause of postpartum hemorrhage. And so the idea is that solve for atomy first. Then if the bleeding persists, then you can then start to think about incomplete placental delivery or cervical lactation or any other cause of postpartum hemorrhage. But when you hit that first, and imagine that PhD level, if they're able to hit that first, instead of thinking about where the problem is coming from, that solves a lot of issues. And important is that the bundling and use of the recommendation collectively, rather than offering them sequentially, is essential. So it's not something that I say, oh, we'll start with massage, then go to oxytocin. That's not the way to play. To do the whole motive at once. And that's why sometimes in facilities it's important to have what they call PPA drills. So that I can imagine that one person cannot be giving massaging and giving oxytocin and giving tranexamic and doing everything at the same time. But if you have a drill that knows that when there's postpartum hemorrhage, this person does this person does that, and everything can happen within a period of 5 minutes, that would really go a long way. And important to note that each of the interventions is backed by strong empirical evidence. I think we had gone through a few of that earlier. And also know that PPH can occur outside the facility. However, this should not delay treatment. So what that means is that if a woman comes to you from home, she delivered 4 hours ago, that does not mean that you cannot do the motive bundle. Go ahead and do the entire motive bundle. Of course, tranexamic acid typically is given within 3 hours of delivery, but the full motive can be instituted. You can deliver tranexamic acid if it's beyond 3 hours, but it's important to remember that motive is not only for those that you saw deliver. Anyone that comes with postpartum hemorrhage, use the full motive bundle. Next slide, please. So now there are a few things, and I think we have been trying to mention this earlier. I know we said prevention is key, but the second thing is that a lot of the time, when you don't pick it up in time and intervene in time, the patient can deteriorate significantly. I mean, even the clotting factors tend to be consumed quite rapidly. We start to look at issues where we're trying to look for blood, and the normal saline can no longer do the job. So I think one of the single most important things when it comes to PPH management is early detection and making sure that you're able to intervene in time and use the full motive bundle. Because delays of even a few minutes can significantly increase the risk of severe morbidity and mortality. I think we all know that. So some of the reasons why people delay that, one is there's a delay in decision making. I think, like I mentioned earlier, people still try to use their experience with their eye to decide how much blood has been lost, and that really leads to slow decision making. Sequential versus simultaneous interventions, when we're trying to do things one at a time, of course, the effect will definitely be slower. And sometimes, like I mentioned earlier, there are unclear team roles. So it's important that we're supposed to run PPH drills in our facilities and know if PPH occurs, this person does that, so that everything can happen immediately. And of course, facility readiness, because all the commodities and everything that's necessary needs to be available. Otherwise, you can't say you're trying to go to the pharmacy to look for something when the woman is already bleeding. And I think the last thing to say really is just that I just need to remember what's like the catchphrase, so to say, which is the motive. And it should be done simultaneously. I think we have a poll that follows after this. So I'll hand back over to Shegun, and then we can take the second poll and the next presentation. And we'll take questions at the end. Thank you.
All right, thank you. All right, thank you, Chinedu. That was rich. And I know a lot of you are still processing what you've picked up from this presentation. But let me help you crystallize that, what Chinedu has presented before we. Okay, let me help you crystallize what we've just heard from Chinedu. Okay, so what the data tells us currently is that 512 maternal deaths occur per 100,000 live births, which is among the highest in the world currently. And for our uterotonics, 26% of oxytocin tested failed quality assays. So essentially, many of these deaths were attributable to poor quality uterotonics. Essentially, why we are reiterating that you should not think price, but think quality. And just like Chinedu said, your motivation to treat is the motive bundle, because it encompasses all you can do for a woman suffering that is having PPH at any point in time. Also, all of this is backed by extensive research, which peaked at the emotive trial with over 200,000 women examined. And then the summary of the emotive of the bundle is to prevent, that's giving a uterotonic immediately after delivery. And like Chinedu said, addressing atony first before, and early detection, and then treating using the emotive bundle. Time is of essence because PPH can deteriorate within minutes. Now, connecting this to what we answered earlier, where many of us, over 70% of participants said that detection is the most important part of the emotive bundle. We can all agree that from the presentation by Chinedu, the entire bundle is essential. No one component supersedes the other, and the whole aim is for every woman that has PPH to benefit from the entire bundle. So there's more where that came from. Our second presenter is one of our core M&E focal persons on the SFM program, and she's bringing us real-world data, not from the textbook, not from guesswork, but from 373 health facilities across 7 states, tracking what actually happens when you roll out this bundle to the facility level. So let's welcome Sarah Ligbe for the second presentation. Over to you, Sarah.
Thank you very much, Shegun. Good afternoon, everyone. My name is Sarah Ligbe. I work with the M&E team for this National Mothers Consortium. I'll be sharing what we've learned from our in this market. Like Shegun had mentioned, we have been working in 373 facilities across 7 states over the last 10 months to roll out the comprehensive PPH bundle across these facilities. It's not one of that consortium is made up of 3 organizations. There's Health Strategy and Delivery Foundation, Solina Center for International Development and Research, and Clinton Health Access Initiative. We're funded by Gates Foundation and MSD for Mothers. And we work in Katsina, Kano, Niger, Plateau, Ebonyi, Lagos, and Delta states. So Dr. Chinedu has done a very good job of laying foundation of what the comprehensive PPH bundle is. And now I will be speaking through all of the results that we've seen over the course of our implementation in the health facilities. Since 2020, we have been working very closely with the Federal Ministry of Health and Social Welfare to essentially crash maternal deaths due to PPH. In the early years, that's between 2020 and 2024, our focus was very prevention focused. So we wanted to ensure that the right uterotonics were available in the health facilities for prevention of PPH. But since 2024, we have expanded our goal to focus on a more holistic approach, which is rolling out the comprehensive PPH bundle, which we have heard about. But to reiterate, the bundle includes prevention using a uterotonic, detection using the calibrated drapes, and treatments using the motive bundle. And our focus states, like I mentioned, also expanded with this expansion. But throughout our implementations, 2020 until now, we have continuously used monitoring and evaluation to be able to track progress and measure effectiveness. So the results I will be sharing with us today are essentially from our current phase of work. Before I get into the results, I want to quickly explain where the data comes from. This data, like I mentioned, comes from the 373 facilities that we're implementing in. We collect data from the labor and delivery registers, the pharmacy stock cards, patient case notes, cartographs, and the things that we collect from all of these data sources are delivery information, PPH incidence data, maternal deaths, commodity availability and utilization data. And we collect all of this digitally through ODK. And we have Power BI dashboards that help us to visualize all of this data for real-time visibility for the facility and also at the state level. And then we do a monthly Excel-based analysis on all of this data to identify patterns and trends and see whatever performance gaps are at the facility level and also at the state level. So the numbers that you'll see moving forward are all of this data that we have. All right, since we started, 23 mothers who would have essentially died from PPH are alive because of the work that has been happening in these facilities. Let me explain how we know this. So before the program started, we measured what is called the case fatality rate, which is essentially the number of deaths due to PPH divided by the PPH cases. And what this showed us from our baseline data was that the case fatality rate was 3.3%. What this means is that 3 out of every 100 women with PPH was dying. That's the baseline. And then if nothing had changed, the deaths that we would have expected, if nothing had changed from baseline, the deaths that we would have expected were 93 deaths over the implementation period. This is between June and December 2025, based on the number of PPH cases that we were seeing. But the actual deaths that we measured in that time was 70. So that's 23 fewer deaths. That's 23 women who were able to go back home to their families. And this is a 25% reduction. And aside from that, the PPH case fatality rate had also dropped by almost half. So in December, in the baseline period, that's October to December 2024, we had an average of 3.3%, like I mentioned. But by December 2025, it was 1.9%. That's 2 in 100 women were then dying from PPH. So we know that the lives are being saved in the health facilities, but what exactly is making the difference? This slide here helps us break that down. So here we compared 3 groups of women who had PPH. So those women who had gotten standalone treatments. So the standalone treatments essentially refer to women who either did not receive full bundle or maybe received oxytocin alone or just TXA. And then the second group of women were the women who had gotten multi-bundle for treatment. So that's the massage, oxytocin, TXA, IV fluids, and examination. And then the last group of women were the women who had gotten the full emotive bundle. So that's the motive bundle for treatment plus the calibrated drapes for early detection. And the results that we got were striking. With the standalone treatment, the case fatality rate was 2%. But then with the motive bundle, the case fatality rate dropped by 28%. So this means that 28% fewer women were dying from PPH when they got the motive bundle for treatment than when they got the standalone uterotonic. And then with the full emotive bundle, the case fatality rate drops by 49%. So 49% less women were dying when they got the full emotive bundle. And we know that the calibrated drapes by itself doesn't really treat anything, but then it's a very good indicator for us to be able to begin treatment before the woman is in crisis. But this means that early detection triggers earlier action, which results in better outcomes and more lives of the women are saved. So we know that the motive bundle is working, but then we can see from the charts that only 64% of the women had received a motive bundle in facilities that we're covering. So what essentially happened with the other 26%? And if we look at the breakdown here of each component of the motive bundle, we see that everything is almost 100% except TXA. So TXA is the bottleneck, dragging the motive bundle compliance down to 64%. And this is due to 3 major reasons. The first is that TXA availability in facilities are not very great at the moment. So it's not on the shelf for a lot of facilities to use. But secondly, is the timing. And I think it's something that Dr. Chinedu also tried to speak to in his presentation. That doesn't matter if the woman comes from home, you need to still treat the woman with the full motive bundle. So we saw that in our health facilities, women who would typically deliver at home and get in facilities, some healthcare workers wouldn't administer the bundle because it would have passed the 3-hour window for TXA administration. So something to pick up from today is that regardless of where she delivers, we should administer the intake bundle. And then lastly, the third reason was due to clinical practice, which is something Dr. Chinedu also called out. We saw that sometimes when the cause of PPH is a tear, some healthcare workers would either just administer oxytocin and go straight to suturing, or they'll just suture and skip the rest of the components of the bundle. Or again, to reiterate his point, the key point is that if a woman is bleeding, she gets the full bundle every time, regardless of what the cause of bleeding is. So the cause shouldn't change the protocol of management. So let's zoom out a bit to speak about each of the pillars of this comprehensive PPH bundle that we're implementing. So over the course of the last 3 webinars, we have discussed each of these pillars of comprehensive PPH bundle individually, and now we're presenting a picture of what it looks like from our health facilities. For prevention, at baseline, we had 60% administration, but by December 2025, it was 100%, which is a huge improvement. We have essentially closed this gap. But I want to just point out that one of the reasons for the low baseline was actually a documentation problem. A lot of the healthcare workers were giving the uterotonics to women or not documenting it. So it was a bit of a hassle to get the information. But then there was also a knowledge gap in some of the health facilities. So some healthcare workers thought that if a woman looked stable, then she did not need to receive the uterotonic. But then the program training and also continuous mentorship has helped us to close this gap. For the next pillar on detection, this is still our weakest point. We went from a baseline mean of 1% to 4% at December 2025. And this is due to 2 compounding reasons. The first reason is availability. Calibrated drapes availability is very low across health facilities. As at December 2025, only 23% of our facilities had drapes in stock. And even among the facilities that had this drape in stock, the utilization rate was still very low. And it was due to a couple of reasons. The first is the cost barriers to the women. But also the ward-bed infrastructure, making positioning drape difficult. And lastly, we saw that in some facilities, they would practice rationing practices and reserve the drapes for women that they perceived as high risk. So this could be multiparous women or women who had previous CSs, and only use the drapes for those women instead of using for every woman. For the last pillar, which is treatment using the normative bundle, we moved from a baseline mean of 30% to 64% by December 2025, which is an improvement. We have more than doubled this through the training that happened in the program and continuous mentorship. The healthcare workers were able to pick this up quickly. However, like we saw from the previous slide, TXA is our bottleneck, and closing the TXA availability gap will for sure improve utilization and in turn improve the maternal health outcomes in the health facilities. So what should you take away from this webinar? The first, like Shegun and Dr. Chinedu have reiterated, is that prevention is better than cure. Prevention will make the most impact in improving maternal health outcomes. It's better to prevent than to treat. Maintaining 100% prevention coverage is essential. Every woman needs to receive a uterotonic after delivery, but then coverage alone is not sufficient if the uterotonic that is being administered is compromised. So we need to ensure that we administer quality uterotonics to these women. We need to store heat-sensitive uterotonics like oxytocin in proper coaching equipment and at the correct temperatures. And in places where the coaching is not guaranteed, we need to explore heat-stable alternatives like heat-stable capitocin, which doesn't require the same complex storage and handling like heat-sensitive uterotonics would. And then lastly, we need to ensure that we only procure NAFDAC-approved uterotonics for administration to women that we care for in the health facilities. The next thing you need to take away from the webinar is that you need to use calibrated drapes for every vaginal delivery, not just high-risk cases. Like we have reiterated, detection is a very important part. It will help you objectively measure the blood loss so that you can already start treating the woman before she becomes critical. The third thing to take away is that you need to apply the complete motive bundle for every PPH case, all 5 steps every time. It doesn't matter the cause of the bleeding, doesn't matter when the woman came from her house to the facility, it doesn't matter if the woman even stops bleeding halfway through the bundle. You need to administer every single step of the bundle at the same time. And lastly, the very important thing to ensure that all of these things actually happen is that we need to close the commodity availability gap. So all of the commodities, calibrated drapes, TXA, HSC, they need to be available in the health facilities. They need to be affordable so that women can buy them for their care, and they need to be in use. So at the health facility level, these items should not just sit in pharmacy. They should be in the labor ward and they should be used routinely. And if they are unavailable in your facility, request them through the proper state procurement channels. At the state level, this means that we need to ensure the last mile delivery for these commodities are complete in time, so that the facilities are not experiencing stockouts and are not able to use the commodities when they need to. We need to address procurement bottlenecks, and we need to also advocate for supplier pricing so that the cost doesn't also prevent the women from receiving life-saving care. Thank you.
Sarah, thank you. Real data from real lives, and shortly we'll just lock in what we've just heard. So just for context, as Sarah gave, the Smart for Mothers program has been at this since 2020, starting with prevention and evolving to the full emotive bundle rollout across 7 states and 373 facilities. So data is collected, like she said, and the essential use of this data is learning and course correction. So what have we seen that is working essentially? Prevention, the coverage for prevention is now at 100%. It was at 60% at baseline and improved after we identified documentation failure and trained facility staff. For treatment, motive bundle use has more than doubled from 30 to 64%. Training mentorship work, but there's still a lot of bottlenecks that need to be addressed. TXA appears to be the weak link, with only 65% of cases receiving it. But the principle that we are trying to integrate into our minds today is for everyone to give the full motive bundle regardless. The critical gap also that Sarah mentioned is use of calibrated drapes with just 4% as of December 2025. So you can't always predict who will bleed, but you can do all within your power to ensure that you detect early and address to the best using the emotive bundle. So just to remind you that from everything she said, for your delivery packs, for your treatments, we want you to think about the quality and not price. Focus on the quality when you're putting together your delivery packs to ensure that women benefit essentially from this. And making reference to our initial responses, we can see that many of us were not confident in the fact that our facilities could handle these treatments. And some of these gaps are what Sarah mentioned in her presentation. So we'll just use the next few minutes now for questions and answers. Dudu and Shamsia mentioned that PhD educators should be trained on modern techniques to tackle PPH. And this is something that as a program, we are fully aware of. And even our expansion program, expansion efforts currently are aimed at reaching PHCs and more underserved areas. And just like Dr. Yini mentioned earlier, these are also some of the commitments of the federal government. So Dudu, Shamsia, hopefully with our expansion efforts, we get to work with you as well. So if we have any questions, please let's drop it in the chat box. We want to answer these questions as we go. If we don't have questions, we'll move, but we want you to drop your questions so that we address it and the communication is essentially rich for everyone. All right. All right, thank you. I can see some questions in the chat box and they are being addressed to by members of the team. So we've heard about the evidence, we've seen the data. Now let's hear from the people that are doing the work. The people who wake up every day in the facilities, in the state ministries, and in labor wards to make this real. So for this session, I'm going to hand over moderation to my colleague, Hawa Ahmed. She's the demand generation lead at Smiles for Mothers, who will bring our panelists into this conversation. But first, let me introduce them. So we'll be having two broad perspectives today. The Ministry of Health leadership, which is going to be represented by Fam Adamu Gachi. He's the Director of Pharmaceutical Service, Katsina State Ministry of Health, and SWAP Desk Officer. So he brings the commodity procurement and policy perspective. Hajia Mansoura Yahaya, she's the MNCH Coordinator, Kano State Ministry of Health. She represents state-level coordination and the journey of embedding PPH protocols across a system in a state. For the facility-level clinical experience, we have Dr. Nuruddin Onaolapo. He's an obstetrician and gynecologist. He's the medical director, Ikorodu General Hospital, Lagos. He brings us the frontline clinical perspective of a busy secondary facility. Matron Rachel Kwanye, she's the matron in charge of maternity at JBNM Hospital, Mina. She brings us the nursing and ward management lens and what it actually takes to handle PPH at the facility level. So I'll hand over to Hawa Ahmed to moderate this session.
All right, thank you so much, Shegun, for that introduction. Thank you to our speakers for the insightful presentations we've had so far. We've had conversations around the evidence, we've seen the data, and now we want to shift the conversation from what should be done to how it's actually being done in practice in some of our program states. And I hope the panelists are ready. Okay, all right. So to explore this, I'm joined by the panelists as Shegun rightly introduced them, and they'll be bringing perspectives from across the state levels and the system. So I'll start from the front line with Matron Rachel. From your experience at the ward, what has changed in your practice or in your facility since strengthening PPH protocols and introducing tools like the calibrated drapes and having better access to uterotonics?
Good. Okay, good afternoon, everyone. I'm glad to be here with you. From my experience in the ward as in charge of the Jumai Babangida maternal and neonatal unit of the hospital, in fact, since the beginning of emotive WHO first response to the PPH, in fact, a lot of things have changed because before we usually use a visual estimation to collect our blood measurements, but it's not so now. What is going on now is we are using this calibrated drape to collect our objective blood measurement, which is very, very accurate and make us to be alert. No matter what the blood loss, starting from the 300 mils or above, we start the triggering of the emotive bundle treatment. We save a lot of lives. Before, we have recorded a lot of maternal mortality, but in fact, since from the beginning of the WHO program, we record just very, very few maternal deaths. And most that even comes to the facility as a referral, we have been able to tackle them well, and the outcome is very positive. In terms of a calibrated drip, it is always been in supply, incorporated with our delivery pack, and the charges is what the patient can afford. So no patient that delivered without no drip. Every patient has a calibrated drip. And in fact, it really helps and it saves lives. The use of our uterotonic drugs, we have the oxytocin, We have the misoprostol, and we have the carbetocin. But the most important one that we use, which is very safe, very cheap and affordable for the patient, is the oxytocin and misoprostol. And in fact, it has been in supply, the quality is good, and in the facility, the power supply is very stable, making it very, very qualitative to use for the patient, thereby reducing the maternal and maternal death in the facility. We have the PPH protocol guide that is always guiding the staff in the ward at any shift. There is no fear that a staff doesn't know what to do when there is a PPH emergency. Everybody go to the PPH protocol where it is being pasted. You read it every day, just you memorize and practice it all the time on the patient. And it works very well because by the PPH protocol guide, you start with your all the early detection, the massaging, the oxytocin, the IV, and the tranexamic acid, examination and escalation. In fact, it has really changed a lot of stories that before it scared the facility that there is a lot of maternal death, but now, in fact, we are no more recording maternal death any longer. Thank you.
All right. Thank you so much, Ma. It's great to hear the positive changes you've been having at your facility, how you've shifted from estimating blood loss to using the calibrated drapes, and how you have been able to record fewer maternal deaths in this past few months. It's really good to hear that. And I'm glad that we can actually see how these changes are making a difference in real time, which also raises the question of how these kinds of improvements are actually built into the system. So Dr. Onaolapo, can you tell us from your experience what practical use of the emotive bundle has looked like in your facility, both for cases that have been detected in the facility and those that have been referred in? Maybe if you could share one example that stands out to you.
My for mothers, the pleasure, the privilege for me to be on this webinar, the emotive bundled care. Of course, we all know the one of the common cause of maternal mortality is postpartum haemorrhage, and over time, efforts have been made to bring back the number. So since the advent of the bundled care, there has been improvements to the management of patients. Over time, in the last 1 year, 2 years, Society for Mother and some other organizations have been training our doctors on how to manage patients using the bundled care. So, as a facility, please, one, we have our delivery packs, which contain all the commodities, which includes, that we refrigerated. Within the course, tranexamic acid, when patient is in labor, they are before we started, some nurses were trained on how to use the bundle care. When patient comes in, they are monitored after delivery, the drape is applied, and that continues. For every patient, we have a delivery pack, the components, the tranexamic acid, IV fluids, the drape, so that monitoring is the essence is to prevent the occurrence of the postpartum haemorrhage and early detection. Over time, the last from about December till last month, the figures I saw, every month we have about 200 to 260 deliveries per month. The PPH prevalence, sometimes we have about 3, 4 in a month. But now, following the use of adherence to the use of the bundled care, patients have less early detection. So, in fact, I think January, February, had only one case of postpartum hemorrhage, which has affected him. As against the previous time when patients or the patient started now give us we have been looking for tranexamic acids, whereas I've been looking for microphosphate. But here, with the body care, each and every patient have their pack, everything in there ready to use. So that has said a lot. In order to maintain this protocol, because my hospital is a training center, from time to time we have training. We have our officers coming in and out. Medical officers are transferred. Some travel abroad, the JAPA, so both of these are continuous, and the matron in charge of the labor maintains that culture. And that has taken a lot in reducing the prevalence of postpartum hemorrhage on our wards. Then we also have patients coming from outside. Our hospital is also a referral center. I know the Center for Mother also trained doctors in primary health centers. So the center also they use the calibrated drapes. So there's early detection. So there's some other health center that have not started using that. I know that the drapes at the point of around November, December, January that the drapes started coming in. The point that was the drapes is now everywhere now. So that's helped with early detection and the management of the patient. Also, the now referred patient area, still have pockets of patients that are referred late, either because patient has bled so much or probably patient presented to the center late. So we have quite a number of maternity homes, auxiliary nurses, to be nurses. So that's so they also try to maintain supply chain. So oftentimes we have the house stock out. But when we have when it's not about 25% to the 25%, so quickly we restock so that there is no issue of stock out. The public care has really helped a lot. Almost everybody is aware of the care, the matrons, the doctors that work in labor, and that's greatly reduce the prevalence of postpartum hemorrhage. As I've said sometimes, I think we need 2 months, we didn't have any postpartum hemorrhage. So they are started early, you know, we're not able to, because they say, okay, the EBL, 50 mils or 60 mils, you know, it's almost impossible. With the use of calibrated, we now have accurate measure of the blood loss. So that have helped a lot, and I want to encourage all centers that are not keeping to the use of this body care. Pack the commodities, and when you have patient admitted to labor, you have everything ready. Patient delivers, the blood loss is measured. If there's any sign of deterioration, then immediately the senior ones escalate follow the care, administer everything, all the drug. Something is administered, they ensure that the placenta is delivered, procedure is monitored to ensure that patient is no ongoing bleeding, blood pressure is not going down, the pulse is not increasing. So that immediately action is taken, and unlike before that you'll be waiting, patient will have going to shock. The patient is identified to have postpartum hemorrhage. But now there's early detection, there's early referral, and that has really helped a lot. And also across the state, so we have national state meetings across, but the number of deaths from postpartum hemorrhage has reduced dramatically. So we now have more preeclampsia cancer as our leading cause of maternal mortality in Lagos State. Thank you very much. That's my submission for now.
Thank you so much, Dr. Onalopa, for that detailed description. It's wonderful to hear the improvements that you've made in your facility over the past year in also reducing PPH cases, taking in referring patients, and also the progress you've made in preparing for these cases, using the calibrated drapes and monitoring the patients effectively. It's really wonderful to hear all that progress that you've made. But of course, even with strong efforts at the facility level, there are always broader challenges that can come into play. So that's why I'm directing my next question to Hajia Mansoura. From your experience, what are some of the key challenges that make it difficult to consistently use the bundle? And what would you say has worked in improving its use routinely in facilities?
Okay, thank you so much for this question. So I think from my end and based on experience, given the the resources, the leadership actions, and then realistically what can give us this. So first of all, institutionalizing simple standard attendance protocols, both at the state level and then at the facility level as well. especially which this can clearly ensure that maternity unit adopts clear, visible management protocols for the emotive or rather the PPH bundle, which they can display in the labor ward and regularly reinforcements of all those protocols during clinical meetings and other things. And I can testify to that, like in Kano State, majority of our facilities that have been trained on the emotive bundle, they have adopted that and they have all the protocols pasted in their labor rooms to give them a kind of reminder. And another key thing is, I think, the prioritizing the low cost, high impact generally, especially if we look at the PPH bundle, they truly play a critical role in addressing all key issues of having the items, for instance, the carbitocin, or the tranexamic acid, the oxytocin, and the IV fluids in different places. So putting things together in one place, I think that's one of the key things that really will really help. And then it has to be frequently be checking for stocking, and then accountability is key as well. Another key thing I think that can also strengthen that is strengthen the team-based response. We should be having a kind of drill sessions in our facilities that will also really help, meaning that we should be having a kind of regular on-site simulation drills, even if it can be on a mannequins, so that the staff can also get it right until they perfect themselves. And repetitions brings about perfection. If the staff has always been practicing and then they're always doing the right thing according to what they've been taught, I think that will be long a way to effectively strengthen the system as well. Then another key thing, like in Kano, as you rightly mentioned in some of your presentations, so in Kano, we train both secondary and PHCs. Through the task shifting and then the role clarity, set a kind of different perspective for them. Now HU can be trained to give all necessary things that an SBA could give, and then that can also strengthen the system. And another key thing, which I can clearly see from your data you presented, is strengthening the MPDSR. So using platforms like the MPDSR, it can help the leaders to identify and address a lot of challenges that can hinder the system to work effectively in as far as PPH bundle, or rather the broader perspective of maternal mortality is considered. So, and then like we rightly mentioned, if we're looking at PPH or the emotive bundle, we need to ensure at least we have a minimum commodity availability across all the facilities. And also, I think what we can also do to strengthen this is supportive supervision. I think these are key things. And we shouldn't forget that improving the PPH response is not only about more resources, it's about better organization of what we already have at hand, with just simple tools like the calibrated drapes, clear leadership roles, team working, and ensuring quality of care is institutionalized across everything. And then I think even with the resource constraints, facility can save more mothers than ever before. Thank you.
All right, thank you so much for that response, Hajia Mansoura. I especially like the points you made about strengthening the system to ensure that commodities are available. So commodities like the drapes being available is also really important. You also talked about NPDSR, which I agree is something very critical to helping us understand how to improve our facilities. And also having everything in one place, like you mentioned, I think it's something that's going to really help with timely treatment of this PPH once it's been detected. So thank you so much for that. I would like to take this one step further to the system level. So Farm Gachi, I want to direct this question to you. So how is the ministry supporting facilities to align with the WHO recommendations on uterotonics for both prevention and treatment, particularly in ensuring the availability of the right commodities? Gachi, if you're speaking, you're muted. We can't hear you. I think he's having some internet connection problems. Let's see if he's able to reconnect within the next few seconds. I think he's still having internet connections. In the meantime, Hajia Mansoura, is this something you can help us shed some light into? What would you say are something that the ministry should support facilities to help align with the WHO recommendations?
Hello.
Okay, I think he's back. Good afternoon, Famgachi. Can you hear me now?
Sorry for the break.
It's okay. I was asking a question. Can you hear me now?
Yes, please. Sorry, my phone was overheating, so I had to restart it. Sorry for that.
No problem.
Yeah.
Can you help us shed some light into how the ministry is supporting facilities to align with the WHO recommendations on uterotonics for prevention and treatment, particularly in ensuring the availability of the right commodities at these facilities?
The ministry is taking. Okay, thank you very much. Good afternoon, everyone. The ministry is taking a multi-pronged system approach to align with the 2018 WHO recommendation towards policy and guidelines alignment. The national state clinical guidelines have been updated to reflect WHO recommendation on oxytocin as first line where cold chain is reliable. And also misoprostol where oxytocin is not feasible. We have introduction of heat stable carbitocin in selected settings. We had Solina here with us, in which they helped us in development of the essential medicine list for the states. Also, we ensure commodity security. We do have a farmer grade warehouse in the states where UNICEF has helped the state in development of this very mighty warehousing system, in which we have cold chain equipments that are readily available to ensure these heat-sensitive commodities are stored appropriately. Am I communicating, please? Can you hear me?
Yes, we can hear you.
Yes. So, leveraging on this platform like the UNICEF, UNFPA, and Global Fund Support System, we strengthen last mile distribution and logistics management system to reduce stock out. And also we ensure the cold chain optimization, ensuring that oxytocin potency through improved storage and temperature monitoring system are put in place. And also the issue of forecasting and quantification through the Logistic Management Coordination Unit in the state. We use the consumption data and program targets to ensure that we have good forecasting, also in alignment with the maternal neonatal mortality reduction innovation initiative MAMI program. We are reaching out to the rural areas to ensure these commodities are taken to the last mile, and also the introduction of the e-motive innovation, promoting the bundle-based, protocol-driven care, standardized rapid PPH response. Well, overall, the focus is on the right drug, right place, right time, and the correct use of the drugs. And also, trainings have been conducted across the states to ensure the e-motive is understood by each and every healthcare provider. And this is an emergency. PPH is an emergency case that needs to be given prompt attention. The early detection is very key in this. We ensure the e-motive bundle is taken across the facilities with the protocols available. We had support from Solina International, and a lot has been done in this area regards to training on the e-motive bundle. And also a lot of other things are ongoing to ensure crashing maternal death across the states. The last time we had data from the MPDSR in the states, actually PPH had the highest contribution to maternal death, followed by eclampsia and then sepsis. So this is a welcome development to the states. The issue of calibrated drape actually is also provided, but not in large quantity. It's a red flag, as the previous presenter rightly pointed out. In my 20 years experience in the civil service, I think it was only last year that I was able to actually see the calibrated drape, which is very important in detecting the postpartum hemorrhage. So we will ensure that each and every facility uses the drape and should be able to prevent, detect, and manage PPH within minutes, not hours. So it's something that has to be an emergency. Should be given all attention with emergency, approach. Thank you very much.
All right, thank you very much for those responses, Pamgachi. I think it's incredible how you've talked about the systems you have in place in these states. So from providing the warehouses with the cold chain structures to providing the logistics and coordination management systems, and also using the consumption data to stock up these facilities with the commodities required. I'm also really glad to hear that you're also talking about the limited quantity of calibrated drapes that we've been having, and glad to hear that you're also looking at having them available in all these facilities moving forward. So thank you for that contribution. I think what really has come out of this panel session is how critical alignment is across all levels. So from what's happening at the wards to the facilities, everything is structured, and supports provided at the state level is also helping to ensure that there's timely and effective response to PPH in our facilities. I would like to sincerely thank the panelists for your time and for sharing your experiences and insights on this call today. And I will hand over to the moderator, Shegun. If there are any questions in the chat box, I think we can look at that as well.
All right, thank you so much, Hawa. Great insights drawn from this panel discussion, views from facility level, from coordination level at the state. I think one important question it had been addressed by Dr. Chinedu in the chat box, but just maybe 30 seconds for maybe one person from the coordination level to just give their answer and one from the facility level. So Maybe for the cognition level, Hajia Mansoura, someone asked, would you agree that evidence is suggesting that in the real world, HSC shows more effectiveness for PPH prevention compared to oxytocin? So is it something you can just give a 30 seconds answer to? What are you seeing at the state level? Okay, hi Hadia, did you hear me?
No, can you comment?
Okay, so I asked at the state level, what is it looking like? Someone asked what the evidence is showing, even at the state level, in terms of how effective do you think HSC is in real world compared to oxytocin? Is something you can speak about, just 30 seconds?
Yeah, absolutely. Even from our own end, I think people really do recommend HSC, that the heat stable carbitazine, to be more effective than the oxytocin, because we all know that the heat stable carbitazine can be kept. It's a heat stable carbitazine, so it doesn't require the cold chain system. While for the oxytocin, it needs a kind of cold chain maintenance. If not, the potency is altered. And then even the content, some research affirmed that the content, some of the producers, the manufacturers, that some of the companies have issue with the oxytocin. That's the active ingredient is not up to the level that is required to be to give us the right treatments or rather prevention. So instead of giving one vial, the 10 international unit as recommended, we need to give like 20 or 30. While for the heat stable carbitazine, only adults will suffice. I can also testify to that. I usually bled after delivery, but then during my last delivery that I was given the heat stable carbitazine, I see a lot of improvement. I didn't bleed at all, and I think I can also testify to that. Thank you.
All right, thank you so much, Hajia. That is from a cognition perspective. Thank you. Matron, is this something you can speak to? What's the evidence like at the facility level in terms of the use of HSC compared to oxytocin in terms of effectiveness, especially for a real world setting like ours where quality and cold chain cannot be guaranteed? Can you speak? Matron Rachel, is this something you can speak to? Okay, so if Matron is unable to speak, I think Sarah you had answered this. Is something you want to just speak, just add a little more context based on your data?
Yes, thank you, Shegun. I also wanted to add to what Haji and Mansoura had mentioned. Even from our facility level, from the real world data that we're collecting, we've also seen that HSC has performed better than oxytocin, and even instances where oxytocin was combined with misoprostol. The PPH rate for HSC was 0.83, and compared to oxytocin, which was 2.23, that was 63% lower PPH associated with HSC. So I would say that in real world evidence, in real world context, using HSC for prevention can be more effective than oxytocin.
Thank you so much, Sarah. So I think I want to appreciate our panelists for the rich discussion. Appreciate everyone that has asked their questions, all the answers received from our team members. So we have a poll at the end of this session. Your comments and insights are valuable to us even at the end. So we want to get your answers. So essentially, you can use the same QR code if you've not. Use the QR code to scan and then give your answers to the questions. Okay, so this is a picture of what it looked like when we answered at the beginning. So we can answer again now with our thoughts, having gone through this through each of the sessions, we can provide our answers right now. So we see what our thoughts are at the end of the presentation. So we can see more people answering. Let's get our answers. Please go ahead. Which component of the emotive bundle do you believe is the most important? So let's give our answers. All right, so the next question is, what is one action you will take to strengthen PPH detection or response in your facility? This is open-ended for you to just say what one action you will take to strengthen. You can just type this. What is one action you will take to strengthen? Okay, early detection. Yes. Okay, so early detection, essentially, early detection, availability of drapes still for detection. So essentially, we can see that many of our participants understand the importance of detecting early, yes. Advocate for commodities, yeah, commodity availability. Okay, so I think as our responses are coming in, I will just do a very quick recap of within a minute of everything that we've gained from this. So essentially, all our presenters and panelists essentially are all directed in moving in one direction, which is that no woman dies from PPH, which is preventable. So essentially to detect every woman, not just one who looks high risk, apply the full bundle across board. Prevention is not optional. It is actually standard and it is the cheapest, where we've said you should not think about price, but think quality, with all of this backed by evidence. For as many of us, our facilities, which fall under areas where our coaching cannot be guaranteed, they, just like Matron mentioned, the delivery pack is actually a very, very unique opportunity for you to put together all the components for prevention and the treatment of PPH in one package for the women to be able to receive at once. And speed determines survival. So from all we've presented, we hope that you want to stay connected to our work. You can find us at the Smiles for Mothers page on the CEDAR website. And we also want to drop a link for you to subscribe to our newsletter in the comments. Also, we'll send a follow-up mail after this with the link for you to subscribe. So you can subscribe and then be able to follow up on more of our work. So on behalf of our entire team, Dr. Yeni, our panelists, Nonso, the entire SFM team, want to thank you for being here. Thank you for the work you do and for caring enough to stay until the end. So goodbye, and we hope to see you next time. Thank you, everyone.
Thank you. Goodbye. Thank you.
Thank you, everyone, and bye for now.
Thank you, everyone. Thank you.